Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today I thought we could get into giving a good consult as well as dealing with a difficult consultant. This is one of the key skills that we have to have in emergency medicine, as well as in critical care, internal medicine, pediatrics. I've been in emergency medicine for about 20 years, which, kind of tongue in cheek, I've probably called about 8 million consults. And I have learned a lot along the way on how to do this better from having done it really wrong. So I'm going to share some of those tips. And then in the second part, we'll kind of talk about some of those ways to deal with a difficult consultant. So tip number one is to lead off by establishing who you are and make sure that you're being polite. So I would phrase this something like, hey, this is Dr. Swami, one of the attendings down in the emergency department. I'm calling to request a consult. Very simple, straightforward, but it really shows the professionalism that you are reflecting and that you are expecting from your consultant as well. Tip number two is to start with the end. The vast majority of your consultants don't want to know how the patient got to you, how you got to the eventual diagnosis. They want to know right off the bat why you are calling them. So if I'm calling orthopedic surgery because I've got a patient with a septic joint, I'm going to phrase it something like this. Hey, Dr. Gill, I'm dropping you a line because I've got a patient down here with a septic left knee, and I'm going to need a little bit of help with this patient. Then I get into a little bit more of the details. This is a 43-year-old man, no past medical history, 3 days of left knee swelling and pain. There's been no trauma, x-rays are negative. I put a needle in the joint, got about 50 cc's of purulent material, and the cell count is 181,000. I've started the patient on antibiotics. I think they're going to need a washout, which is why I'm dropping you a line. And then finally, I'm going to close the loop on communication. Dr. Gill, when can the patient expect to see you? And if you need to get in touch with me about anything, here's my number. Let me know if I can do anything else to help. Properly requesting that consult sounds pretty easy, but it is critical to get done what you need to get done. And in that presentation, you've established the professionalism, established why you're calling that specific consultant, what's going on with the patient, and then closing loop to make sure that the consultant understands that you are expecting them to come in, see that patient, and then give you a disposition. Honestly, in some ways, giving the consult is the easy part. It's what to do when you get a little bit of pushback from your consultant that can really give people some angst and some angina. What we have to make sure when we are doing this, when we're dealing with that consultant that maybe not responding the way that we would like them to respond, is to keep the patient at the center of everything. It's not about you. It's not about the consultant. It's not even about the hospital. It is about the patient that you are seeing and that they need the consultant that you are calling. So let's go through a couple of tips on what to do when your consultant isn't responding the way that you had hoped. Either they are refusing to see the patient or they're refusing an admission. Tip number one, the first thing I'm going to do when I get that pushback is to ask why. Why is the consultant declining to see the patient or declining the admission? Often this is going to reveal an issue in miscommunication. Perhaps you've called the wrong consultant for the issue at hand, or perhaps the consultant doesn't quite understand what issue the patient is dealing with and why you're involving them. Sometimes the consultant isn't actually declining, but rather they're trying to communicate that they can wait to see the patient in the morning or wait to see the patient after admission. That just might not come across clearly. And so asking that why might get that response back from the consultant. Oh, yeah, I agree. I need to see that patient. Admit them to the medical service. I'll see them in the morning. Asking why gives you the opportunity to clarify the emergency nature of the consult or to accept the fact that your patient is in fact stable and can wait to get that consult until later. Asking for clarity will often get you, and more importantly, your patient, what's needed without creating additional conflict. But what if you do that and you don't get clarity? That doesn't resolve the situation. This is where I'm going to move back to restating my case and then asking for an alternate plan. Restating the case itself, again, might get the consultant to understand your perspective, why you need them involved. But what I usually see happen is that I restate the case and then I simply ask, what do you recommend I do instead? Or who do you recommend we call to help and care for this patient? What usually happens in this situation is the consultant hears that repeat presentation, they hear that question of who do you think I should call instead, and they realize that in fact they are the one to help to take care of that issue, and they agree to either come in to see the patient or admit the patient and then see them later. Of course, there are times where I restate the situation. I ask the consultant, who do you think that I should call instead? And they say, oh yeah, you should call ENT, or you should call GI because I don't actually handle that particular issue. So that gives you, again, that clarity that helps to determine if you have the right consultant, if not, which consultant you need. And it might even tell you that you need to transfer the patient somewhere else to get the consultation that's required. Either way, restating my case and asking for an alternate plan gets what myself and the patient needs, which is clarity on the situation and a path forward. Of course, there are times when all of this goes as you would like it to, but the consultant still refuses. The first thing to make sure is that you are crystal clear that the consultant that you have on the line is the one you need for that patient. But if it is, and you are sure that your patient needs that consultant, and the consultant is still refusing without a good reason, it's time to pull out all the stops, the weapons of mass destruction, leaving no out for your consultant. The first thing I'm going to do in this situation is try to make it a little bit more personal. This is the what if it was your mother or what if it was your kid approach. And as ridiculous as this sounds, it often gets the consultant to reconsider their position and do the right thing. Number 2 is appealing to a higher authority. I hear that we disagree on whether you need to come and see this patient or not. Since we're at an impasse, I'm going to have to escalate this to a higher level. That's going to be followed by either you contacting their attending if you're working in an academic shop and it's a resident consultant, or maybe contacting the chair of the department, or even contacting the hospital medical director in order to get the situation taken care of. Rarely have I had to use this topic, and it almost always results in the consultant doing the right thing, coming to see the patient without you having to actually escalate to that higher authority. Finally, if none of that works, I let them know that I'm going to have to document in the chart the refusal to consult. Again, I have rarely had to pull this out. I don't like putting that in the chart, but there are times where you know that the patient you're seeing needs that specific consultant. You can't get them to the bedside, and so it's important for you to document what has happened. Once again, the reason why I rarely have to do that is because even mentioning it usually gets done what needs to get done for the patient. Remember, with all of these tips, all of these tricks to getting your consultant to do what's necessary, you have to keep the patient at the center of all of this. They are the center of the conversation. It's not about you. It's not about the consultant. It is about that patient and what that patient needs from the consultant that you are calling. All right, well, that's it for this week's podcast. Don't forget to tune back in a couple of weeks for another cast. And in the meantime, don't forget to pop over to the Rebel EM site to check out all of the fantastic work that our team is doing. And until next time, stay safe.